The guidelines tell us that we should look at the uterus, the adnexal structures, and the cul-de-sac for presence, location, and size of myomas and adnexal masses, and that we should look in the cul-de-sac for the presence or absence of fluid. Here we can see a small fibroid sitting right behind this gestational sac at 10 weeks gestational age. And here we can see a molar pregnancy that is seen in this case with a viable fetus along with it, but often our molar pregnancies will be seen in isolation as these multiple large irregular cystic spaces within the uterus. In 2007, the guidelines recommended that we consider doing nuchal translucency measurements in order to assess risk for trisomy 21, 13, 18, and anomalies, such as cardiac defects, because fetuses with congenital heart disease often have an enlarged nuchal fold. There are very strict criteria for doing this technique, and it requires certification in order to be able to take adequate images that can be used accurately for a screening. Basically, if the measurement is greater than 3 millimeters, it is worrisome for a karyotype abnormality. And in this diagram, you can see that the fetus occupies about 75% of the image from the chest up to the head, that we can see the amnion separate from the chorion, and that when we measure it, we need to be very accurate on exactly where we put the cursors, as this is the correct placement. On the left-hand image, we have a normal nuchal measurement of 1 millimeter. In the middle image, it's 3, which would be borderline to abnormal, and we would need to correlate it with our blood test to be able to give a specific risk. And then on the right, you see the 10 millimeters, which is clearly abnormal and would be very worrisome for a karyotype abnormality. Now I'd like to go on to the second and third trimester guidelines. The indications for second and third trimesters is much longer than for first. You can see estimate gestational age, fetal growth, vaginal bleeding, pelvic pain, incompetent cervix, fetal presentation, multiple gestations, adjunct to amniocentesis, size dates discrepancy, pelvic mass, suspected hydatidiform mole, cervical cerclage placement, ectopic pregnancy, fetal death, uterine abnormality, fetal well-being, amniotic fluid abnormalities, placental abruption, external cephalic version, premature rupture of membranes or preterm labor, abnormal biochemical markers. Abnormal biochemical markers, follow-up for fetal anomaly, follow-up for placenta previa, history of previous congenital anomaly, fetal condition in late registrants for prenatal care, to assess for findings that may increase risk for aneuploidy, that is a new one for the 2007 guidelines, and screening for fetal anomalies. We need to look at fetal cardiac activity and notice whether the rate is abnormal and irregular or whether it's normal, and that rhythm should be reported in the report. We need to identify the fetal number again and the presentation. The presentation will be cephalic in the upper first line of box A. In the second, it'll be breech. The third, it'll be a transverse lie with the head to the left. And then the next one would be transverse lie, head to the right. And you can see the variations of all these need to be dictated in your report. Multiple pregnancies, just like the first trimester, we need to identify the amnionicity and chorionicity, because this makes a great impact on how frequently we could study these patients. Need to study them in order to find the complications of twins, and they do vary significantly based on the amnionicity and chorionicity. We need to do a comparison of fetal size and estimate the amount of amniotic fluid on each side of the membrane. We generally do a single pocket. The guidelines tell us we should at least say whether they're increased, decreased, or normal, and they do suggest that we should look at the genitalia and report it. And that's because the genitalia will help us with the amnionicity and chorionicity. If they're different, a boy and a girl, it is likely that they came from two eggs, diamniotic, dichorionic. This is true most of the time, but occasionally patients with infertility do not read the books, and they occasionally have came from the same egg and still have different gender. We also look at the placenta. If there's a single placenta, we don't know, but if there are two placentas, we know that it's diamniotic, dichorionic. And then lastly, we look at the membrane. When we evaluate that membrane, we need to determine whether it's thick, thin. Some people will actually look at the number of layers, but the twin peak is very important in making this differentiation. Now, Dr. Sebayer called it the lambda sign. Other people call it the twin peak. It basically is when placenta is growing up between the two layers of the amnion. Whereas in a monochorionic placentation, you can see that the placenta cannot grow up in between the two layers of the amnion because that chorion is holding it back. Now, if you look at this picture of the placenta, it makes sense why you sometimes will see the peak and sometimes not, because if you have a section on the ultrasound coming through here, you might not see any twin peak, whereas if you went right through here, you would see a very nice twin peak. So the point is that the placenta grows up in patches. It doesn't grow up along the entire membrane. On the left, we see a twin peak and a diamniotic dichorionic placenta, and on the right, we see a very thin, wispy membrane floating adjacent to the limbs of this fetus, and we see no twin peak. This is a diamniotic monochorionic twin. Triplets will have variations on the theme of amnionicity and chorionicity, so that you can see a very thick membrane between B and C, so that would be a di-di. And then on the, there's either no membrane, which you can't see here, or there is a very thin wispy membrane going in between these twins, and that would be important. We need to compare the size between the two twins in order to assess them for intrauterine growth retardation between the two. Amniotic fluid, we use the single deepest pocket in order to assess these methods. Certainly, if the pocket is less than 2 centimeters around a fetus, that is worrisome. In general, when we look at the amniotic fluid index in singletons, if it is between 5 and 20 centimeters, it's normal. If it's less than 5 centimeters, we're quite concerned about being oligohydramnios. And if it's greater than 20 centimeters, and some people will actually use 25, then we are worried about polyhydramnios. When you look at the 4 quadrants, you basically take a distance, just drop down in order to measure those 4 quadrants, and then a nice curve to the right we see of what is considered to be within normal limits. And you see why the 20 to 25, it's not perfectly straight throughout gestation. We take that measurement by dropping the line down, and we must have at least 1 centimeter of fluid pocket where we measure that in order to get the amniotic fluid calculation. We take those 4 quadrants and we add them up to get the AFI. The placenta, cervix, and cord also need to be evaluated. We need to state where the placenta is and the appearance of it, its relationship to the internal cervical os. And also we note that the position early in pregnancy may not correlate very well with what will be late in pregnancy, because as the placenta, as the uterus grows and enlarges during gestation, that placenta often moves up and out of the lower uterine segment as it stretches, and what early on looks like a placenta previa later on will not be at all. So anytime we see an early diagnosis of possible placenta previa, we want to bring them back at about 28 weeks. The guidelines also suggest that we should look at the number of vessels in the umbilical cord, and we should also assess for cervical shortening with transvaginal or transperineal scan. So this is a low-lying placenta that is approximately 1.8 centimeters from the cervix, which we can see over to our right here. This is the urinary bladder. So we would call that a low-lying placenta. Now this is a 19-week scan, and you can see that it looks like a placenta previa on transabdominal, and when we go to transvaginal scanning and see the cervix, we can see the placenta is indeed covering the cervix, and that would be placenta previa, and we would recommend a follow-up at 28 weeks. Now, we do look at the placental cord insertion into the umbilical cord insertion into the placenta, but this is not yet in the guidelines. We feel this is important in looking for filamentous insertions. The cervical length measures 4.9 centimeters in the case here shown with the bladder anteriorly. And in general, if your cervix is over 5 centimeters, it's just a little bit too long. Now, if you have a question, you will need to go to transvaginal, as you can see here, and this cervix measures 2.2 centimeters, and you can see the membranes bulging down into that cervix.